Good evening, everybody. I'm Dr. Howard Elkin, medical advocate, and I'm so happy to have you join me today for my second YouTube live series. This one's about integrative cardiology. Now, you might remember from last week, or actually 2 weeks ago, we talked about functional medicine. And in functional medicine, what we're really interested in is getting at the cause or the root of the problem, as opposed to just fixing it. So when I think about functional medicine, I think about the three tenets that actually distinguish traditional from functional medicine. One is that traditional medicine tends to be disease oriented, whereas we're more interested in prevention when it comes to functional medicine. Another difference is that traditional medicine tends to be doctor oriented. Like, I'm the doctor, I know what's best for you. I'm going to order these tests and you get them, and then I'll have to tell you what we need to do after that. Functional medicine is more patient-oriented, so we actually listen to you, and we get an idea of your problems. And I always say, put the patient in the driver's seat when it comes to functional medicine, because I'm really your second opinion, you're your first opinion. And the third distinguishing factor is that in functional medicine, we tend to use a cookie-cutter approach or a Band-Aid approach, like one size fits all. You've seen that, I'm sure. Whereas in functional medicine, we're more interested in customizing a program for the specific patient, depending on their problems and how they present. So when I think about integrative cardiology, it's really an extension of functional medicine. So I'm going to read you a definition that I found. And it's, in simple terms, integrative cardiology is good cardiology. I like that. It applies the tenets of functional medicine to choose the most appropriate treatments for the individual. And that's from the American Board of Integrative Medicine. Now, I don't want you to get the idea that traditional cardiology is bad. It's very important. In fact, like tomorrow night when I'm on call, if someone comes into the hospital with an acute heart attack, my job is to bring them to the cath lab and do everything in my power to open the coronary artery up, and that's an emergency. And traditional cardiology is very good at that. When we think of integrative cardiology, we think about lifestyle management. It's really important. So I think that when I'm practicing integrative cardiology, I'm going above and beyond normal. I'm traditionally trained. That's how I've always learned to practice medicine. But then I go above and beyond and really look into lifestyle. We're talking about diet, exercise, stress management, sleep, the whole gamut. And it's really important about lifestyle because about 80% of the CDC, the Center for Disease Control, has stated that 80% of the health problems in this country that are chronic are related to lifestyle choices. So that's really important. Now, I want to give you three simple examples before we open it up for discussion. One is elevated cholesterol. You all know about cholesterol. Over 100 million Americans have elevated cholesterol. So what do we do about it? Usually, a doctor will order a simple lipid test. That's total cholesterol, triglycerides, HDL, which I call healthy cholesterol, and LDL, which I call lousy cholesterol. And they base their decisions on that particular test. And lots of times, the patient will end up on a statin, which is one of the most commonly used medications. Now, in integrative cardiology, I go way beyond that. So I order what's called advanced lipid testing or advanced cardiac testing. And that gives me a lot more information. There's several labs that do this. I use Boston Heart Diagnostics, and I also use Cleveland Heart Lab, which is now part of Quest Diagnostics. I get really good information from these labs. So what I'm interested in is the size of the particles, whether it's LDL or HDL. I want you to remember one thing. Bigger is always better. The bigger the size of the particle, the less likely it is to form plaque in your arteries. It's very important. Well, how would you know that? You wouldn't know that unless you order an advanced lipid test that actually measures the size of these particles. They also give me information about something called Lp(a), which you may not have heard about. Lp(a) is very sticky, very inflammatory, and definitely will cause plaque in your coronary arteries. You won't know that unless you order an advanced test. But we go beyond that. I also want to know about your inflammatory markers, because all the diseases of aging, heart disease, cancer, autoimmune disorders, and Alzheimer's, they all have one thing in common. That's inflammation. So I'm interested in learning about your specific inflammatory markers. I'm also interested in your metabolic markers. Do you have a tendency for diabetes, prediabetes, obesity, non-alcoholic fatty liver disease, polycystic ovarian syndrome. These are all disorders of carbohydrate metabolism that can be definitely improved with lifestyle. They also look for some genetic markers as well. So we get all this information on the patient, and then I can find a plan that's really suitable, a customized plan. And that's what we talk about with integrative cardiology. Now, a second example is congestive heart failure. And actually the most common cause of hospitalization in those over the age of 70 is congestive heart failure. Now, in the last several years, traditional medicine has come up with some very good pharmaceuticals that not only improve symptoms, but they also keep you out of the hospital, and they can also help prolong your lifespan. They didn't have that when I was a fellow 35, 40 years ago. Now we have that, but that's all we really have. So with integrative cardiology, I'm interested in the nutritional status of the heart. So just think about this. A diseased heart or a heart that doesn't pump well is nutritionally deprived, is nutritionally starved. So I use supplements, things like coenzyme Q10, L-carnitine, D-ribose, magnesium, and we'll be talking about those in future episodes. But that's what we talk about with an integrative fashion, is adding nutraceuticals to pharmaceuticals whenever we can. And the third example is atrial fibrillation, which you've heard about. That's the most common arrhythmia that we see in those over the age of 70. But I'm telling you here that we see it in lots of people of all ages. I've had two best friends develop atrial fibrillation in their early 50s, and they both required ablations to resolve the arrhythmia. The 29-year-old gentleman that I saw a year ago, I had to send for an ablation because he could not be controlled. So with things like atrial fibrillation, what do we do about it? Do we send them right to an electrophysiologist? Do we wait and see how often it happens? Do we study the arrhythmias? I'm interested in the triggers. That's really important. I have patients journal what happens when they get these episodes and ask about their alcohol intake, their smoking intake, how many hours of sleep they get per night, the stress in their lives, fatigue. All these triggers can make a big deal of difference when dealing with arrhythmias. So those are three examples that we see in cardiology practice on a daily basis. And so I hope I've given you a little example of how we do things differently with integrative cardiology versus traditional, and they're both very important. So I'm now throwing it open to you for some questions. And so please use the chat box, and I will do my best to answer your questions. Okay, questions, anyone? Okay, well, maybe I'll ask a question. Oh, here we go. Thank you. The shrink shop. Can you explain what might cause dilated cardiomyopathy? That's a great question. So a cardiomyopathy is a disease of the heart muscle, and the heart becomes enlarged and it pumps poorly. And the end result can be congestive heart failure, arrhythmias, and death. What causes it? I have to tell you that in most cases, we really don't know. So we call it idiopathic. In medicine, idiopathic means we don't know. Lots of times it can be viruses that can cause it, bacterial infections. We see it sometimes with postpartum. I recently saw a 31-year-old that had a case of postpartum cardiomyopathy 4 or 5 weeks after she delivered a healthy baby. We also see it in people that have had multiple heart attacks. They've had such a scarred heart that the heart becomes enlarged and doesn't pump well. But bringing it up today, I think COVID-19, there's definitely a fair percentage of people that developed cardiac dysfunction, and that can lead to a cardiomyopathy. And we'll be talking about COVID-19 probably in my next session. So great question. Unfortunately, it's more common than not. And so with these patients, I used a combination of pharmaceutical therapy that's well accepted, as well as nutraceutical, which I've alluded to earlier. Okay, let's see. Person 100. I've had a heart attack, though mild. Should I be concerned of another? Yes and no. Yes, but because that's when you want to go to someone who does integrative cardiology because we want to know your risk. I don't really care how high your cholesterol is. I mean, I do, but I don't. What I really care is your individual risk. And that's when I see one, and I have a lot of people that come to me after they've had a heart attack saying, I don't want another. What can I do to prevent that? So I do this testing that I've mentioned because it gives me a lot of information, and then I sit down with that person and say, okay, this is your risk, and this is what we can do about it. So my goal when I see an individual patient is that they never have to have a second heart attack or a second bypass or a second stent in their lifetime. And I've had a pretty good track record, but it's really it's a relationship between me and the patient. And fortunately, with lifestyle changes, a lot can happen. Okay, Berkeley, I thought I was having arrhythmia, and then it turned out I was a nutcracker syndrome. Ooh, nutcracker syndrome. I'm not quite sure I even know what that is. Um, it's a new one on me. Um, I'm going to have to look that one up. I don't, unless you can give me more information. Also, I have another one. I have a great diet and good exercise, but my cholesterol was so high. Okay, again, that leads to more information. I have patients that have cholesterol of like 280, 290, or their LDL. The LDL, the lousy cholesterol, may be as high as, let's say, 170, 180. I do not put all these patients on statins. I will tell you that most of my colleagues will because they're told to do that. They don't talk about lifestyle. So again, do I care about your cholesterol level? I do, but I don't. It really depends on your individual risk. And that's what I want you to take away from this little series. Okay, another good question. Is it true that everyone has a finite number of heartbeats in their life? Also, is a resting heart rate of 8290 healthy? Okay, that's a good question. I don't think there is a finite number of heartbeats in a lifetime. A normal heartbeat is between 60 and 100 beats per minute. And that can vary tremendously depending on a patient's overall condition. People that are well conditioned, who exercise on a regular basis, generally are going to have slower heart rates. I just had a patient today, and she was really worried that her heart rate goes like 50 when she's sitting down doing nothing. I said, what are you worried about? Are you dizzy? She said, no. I said, there's nothing to worry about. So I try to get people to not focus on the actual number of beats per minute because we can do testing. Like I often will do a 30-day event monitor, which is covered by insurance. It gives me an idea of not just the heart range of a patient, but if there are any arrhythmias. So again, it's another fabulous tool to use. Okay. How accurate is particle size in determining how much plaque you have? Thank you very much. It's a good question. It does help a lot. I'll tell you why. So I remember I told you that bigger was better, right? Because small particle size is up to 40% more likely to get oxidized, which is a chemical process that takes place. And once it's oxidized, the ability of that cholesterol to go to burrow into your arteries and cause plaque is very high. So again, the smaller the particle size, the more scared we are. And now there's a test that both Boston Heart and Cleveland did that actually measures your oxidized LDL. Like I had a patient today that has a familial hypercholesterolemia, meaning it runs in the family, and everybody's had heart disease at very young ages. And not only does he have small particle size, he has oxidized LDL. So that's like a double whammy. They tend to go hand in hand. So I care about small particle size, and we can alter that. So yes. Okay, esophageal spasm. Okay, yes. Okay, nutcracker syndrome. I didn't hear about that. We used to call it in medical school. We used to call it DES, diffuse esophageal spasm. My aunt had that one time, and she ended up in the hospital. So what happens is the esophagus spasms, and it actually has like a corkscrew appearance if you give like a barium swallow, which no one uses those anymore. And the important thing about it is that it's often confused with heart attacks because it's a crushing kind of pain. It's usually brings people to the hospital on their knees. And it's interesting enough, it actually, because it's a spasm, it actually is oftentimes relieved by nitroglycerin, which we use for heart. So it's confused with heart disease, but there's no correlation, thank goodness. Okay. Okay, that was Nutcracker. Anything else, guys? Okay, let me see. Looking for more questions. Okay, Trevor, at what point is it time to use pharma solutions to the spectrum of treatment? If you are young, how many changes and how long before it's time? Okay, it's a great question. I get a lot of young people in my practice because, although I'm not young, I have because of my interest in prevention, a lot of young people come to me because they don't want to go on medication. And I'm really reluctant to put someone young. To me, young is like anything less than 40. I really don't jump to put them on medication. I always will exhaust lifestyle as much as I can, especially if it's someone who's compliant and really interested. So if you're talking about blood pressure, I have an armamentarium of things that I use before going. So I will really exhaust lifestyle to the fullest. When it comes to either high blood pressure and also high cholesterol, unless they've had a history of heart problems. And then things do change. Okay, so again, what point do I use pharmaceutical? Again, it depends on the actual risk of the individual and if they've had heart disease. Okay, what is the best diet? Okay, that's going to be a whole topic in itself. But I'm going to tell you what my diet is. I'm kind of between Mediterranean and paleo, because if you no diet has been studied more than the Mediterranean diet. There's no question about it. It's been shown to lessen the degree of heart disease, and the can't think of the study right now. But there's a studies that came out in the last 10 years that really proved that point. Paleo is new, and I like it because it basically tells you that if it doesn't grow naturally on trees or run in the wild, it probably doesn't belong to your plate. So there's actually no processed foods in paleo. And there are some processed foods with Mediterranean, but again, it's been studied so extensively that I tend to recommend those a lot. However, again, it depends on the individual patient. If they have metabolic syndrome, diabetes, prediabetes, obesity, I probably recommend something more restrictive in carbohydrates and maybe even go as far as a ketogenic diet. So we'll get more into diet, and we'll really break this down in future sessions. But I love talking about diet. It's one of my favorite things. Okay. What's the best way to get a consultation with you? I love that question. All I do is call my office, 562-945-3753, or you can go to my website, www.heartwise.com. I'm also on Facebook, Heartwise Fitness and Longevity Center, and I'm Doc H. Elkin on Instagram. So you find me there or call my office, we'll get you in. Okay, can you explain how hormones are cardioprotective? Good question. Despite all this controversy that you've heard about with hormones in the past, I tell people that I am biased because I'm anti-aging as well as cardiologist. So I do believe that people will look better, feel better, and think more clearly on hormone replacement. Do I think everybody should be on hormone replacement? No. That's an emphatic no. It really depends on the individual. And as you can see, I'm really into customizing treatment. But cardioprotective, yes, progesterone and estrogen for sure. You probably know that women lag at least 10 years behind men when it comes to getting heart disease. That's because the estrogen has a protective effect on women. It doesn't in men. As men get older and they develop more body fat, their estrogen levels start to rise with their testosterone levels decreasing. So in men, estrogen actually can cause premature heart attacks and strokes. So in women it's protective, in men it's not. And progesterone, which is another hormone that we use in women, is also very helpful. And they together they act as calcium channel blockers. They have to dilate the arteries so that can actually help with blood pressure control. So I think hormones do play an important part. And even in men with testosterone, we now know that testosterone has positive effects on the heart, not negative. And it actually can increase dilatation of the coronary arteries, actually increase circulation to the heart, which is a good thing. So I'm pro-hormone in that regard. Okay. Your approach is young. Okay, here's another one. I have borderline high cholesterol, a minor heart attack, and am on a statin. Do I have to take that with a blood thinner forever? Okay. So I assume this person that mentioned this, maybe if he had a heart attack, possibly he got a stent placed. I'm not quite sure. So a stent is used oftentimes in an acute heart attack to open the artery up. Again, it can be life-saving. especially in the throngs of a heart attack. So those patients do need to be on a type of a blood thinner, not Coumadin or a real blood thinner, but something like we used to call it, but now we call it Brilinta or Plavix. You've heard them before. That is important for a year because you want to prevent platelets from getting into that stent and causing a blood clot. So after a year, it really depends on the patient. If they have severe disease in all three vessels, I might keep them on a platelet inhibitor, but oftentimes I will take them off of it because there are some disadvantages in staying on blood thinner the rest of your life. So I don't think it has to be forever. Okay, the best way to reduce triglyceride. Great question. I love talking about triglycerides because although the Heart Association has never really elevated them to the status of a main risk factor for heart disease, it's not something good to have because high triglycerides tell me that the person is metabolically unhealthy because high triglycerides are associated with obesity, prediabetes, diabetes, metabolic syndrome, non-alcoholic fatty liver disease, polycystic ovarian syndrome. These are all problems that are aggravated by poor lifestyle choices. So when you're talking about best way to reduce it, I go to diet first off the bat. A low carbohydrate diet. I don't care if you want to call it paleo, ketogenic, or something in between. I do believe that those diets will work very well, not only reducing your weight, but also in reducing the triglycerides. I've seen tremendous response to that. People think, oh, elevated triglycerides because it's a stored form of fat. What I need to do is to decrease my fat intake. It's not that. It's not the fat. It's the carbohydrates. Your liver can't handle the load, so it retains what it has to in the liver, and it converts to fat, dumps the rest in the circulation as triglycerides. So when you see high triglycerides, it's usually someone that has one of those metabolic syndromes and also is imbibing on way too many carbs. Other natural things I like to use are fish oil. Fish oil can be very, very helpful in decreasing triglycerides, but I have to tell you, often have to use a large amount. Usually, I usually use 1 to 2 grams for the average patient, but if I'm trying to reduce triglycerides, I will go as high as 4 to 6 grams a day. And it can be very helpful in decreasing triglycerides. Niacin is also useful. Statins don't touch triglycerides. Okay, fish oil. I think I just mentioned fish oil in the realm of triglycerides. To me, a fish oil is essential for anybody over 40. Fish oil, probiotic, and coenzyme Q10. The reason I like fish oil is your natural anti-inflammatory agent. And I know a lot of people that throw in a lot of ibuprofen and Aleve, and these are not healthy to use for long term. They screw up your microbiome, which is very important for your overall health, and they also can cause other problems like GI bleeding and also renal dysfunction. So I tend to get away from them unless I'm treating a very acute problem. I love fish oil. I love turmeric. But fish oil is your natural anti-inflammatory agent. It also is helpful in, believe it or not, depression in elderly people. It also is cardioprotective. There have been studies that have decreased the risk of sudden death from malignant arrhythmias in those taking fish oil. So it's a must in my practice, especially with any cardiac patient. What is the difference between triglycerides and cholesterol? Okay, triglycerides and cholesterol, they're both fats. They're blood fats. Cholesterol is a waxy substance that is actually essential for life. You can't do without it. It's a precursor to vitamin D, sex hormones, bile acids. And so this whole thing about, we should lower cholesterol to as low as we can doesn't ride well with me, because cholesterol doesn't just circulate freely in the blood. It's bound to protein. So LDL, that lousy one I talked about that you've heard about, is essential. If you didn't have LDL cholesterol, you wouldn't have cholesterol going to the brain, which is important to build new neurons or nerve cells, and also the myelin sheath, which protects each nerve cell. So I don't know about you, but I don't want a good heart with a bad brain. So I'm, that's a very big thing for me. so again, cholesterol is not something I try to get down as low as some of my colleagues do. Okay. I go through gallons of olive oil. How do I increase my HDL without a rise in my LDL? Okay, exercise. That's where exercise comes in, especially, although both aerobic exercise or cardio and strength training are both equally important as far as I'm concerned. Cardio or aerobic exercise can play a role in decreasing your HDL. Also, smoking is a great way to lower your HDL. That's a bad thing. Obesity, so weight reduction, smoking cessation, aerobic exercise. Those are all good ways of lowering your HDL. Increasing your HDL. Myself. And then niacin can help increase your HDL. I want to give it for that reason alone, because again, I like to prefer exhausting lifestyle. So again, exercise, smoking cessation, and diet. Okay, do these over-the-counter fat burners damage the heart? Yeah, that's a good question. I don't take any of those energy drinks. I've never taken one. And there have been reports of those energy drinks causing sudden death in young people. And it's because what happens, they tend to prolong what's called the QT interval. You may have heard about that with hydroxychloroquine. That's an EKG diagnosis. So you wouldn't know who has it and who doesn't unless you do an EKG. And we know that in certain people that have that, they're born with it, it can increase the QT interval and can lead to sudden death. They can definitely damage the heart in that regard and actually lead to sudden death. As far as the fat burners, I don't think that's been really well explored. Do I ever use fat burners? Yeah. I mean, when I used to compete in bodybuilding, I would often use like espresso without any sugar or without any sweeteners or milk in it to help, because it's a natural fat burner. But that's about as far as I would go. I didn't feel comfortable with other things because caffeine actually can be very healthy. Okay, what do you think is the single best predictor lab marker of a cardiovascular event? That's a good question. I don't know if we have a singular answer for that. So here's how I do it. I get these specialized lab tests I'm talking about, like Cleveland Heart, Boston Heart. And then depending on what I see, if I see really a fair amount of risk in a patient, I'll then order what's called a coronary artery calcium scan. And that's it's a very 5-minute exam. It's a special CT exam, and it detects the amount of calcium you have in your coronary arteries. I happen to use Harbor UCLA because they have a database of 30,000 people. Let's say you're a 48-year-old male. Okay, so you get your score, and the ideal score is 0 because you don't want to have any coronary calcium in your arteries. So let's say your score is 80 or 800 or 3,000. It can be any of those things. We don't know until you do the test. And I've seen people that look really healthy that have high numbers. And then what it will do, because it does have a large database, it'll say, okay, how does this 48-year-old male compare with other 48-year-old males? Well, he's in the 20th percentile. That's not too bad. He's in the 40th or 50th. That's average. He's in the 90th percentile. That's pretty serious. So I use those two together to help. And again, it's all about lifestyle and what I need to do. But I use those two together: advanced cardiac testing and coronary artery calcium scan. There's new testing that I'm starting to use now, and I'll talk about in another session. It's really new, and it tests really how your body responds to plaque stabilization, because plaque isn't just plaque. Plaque is also your body's way of containing the injury, and there are markers that we're looking at now that can give us information about that. So it's kind of like autoimmune. Your body is, it's making more plaque because it's trying to contain the plaque. So I'm really excited about some of these new tests, but they haven't really hit mainstream yet. So I'm going to wait and discuss those when I get a little more experience with them. Okay. Does a higher protein intake cause a rise in LDL? Good question. Because I get this a lot, especially on my patients that do ketogenic. And they come back and they say, well, my doctor's really upset. My cholesterol went up like 80 points, my LDL. I could care less, because these doctors don't really understand the diet. It can increase the LDL, but we know for a fact, I blogged about this, that an increase in saturated fat, which is what you get when you have animal fat, does not equate to an increased risk in heart disease. Although this stuff has been around since the 60s, we're still going on data that is 50 and 60 years old. But the new data that has come out really doubts the association between saturated fat, which you get in a high protein diet, and the risk of heart disease. So I look at that, and now what about a patient that's got? I have a patient. Okay, I'll give you an example. I have a patient that's about his early 60s. The guy's amazing. He is triathlete. He's a cyclist, competitive. He's got a six pack. I mean, he's in incredible shape, very competitive. And he wanted to go ketogenic, and he's not overweight. He just wanted to go ketogenic because he has a high calcium score. Totally asymptomatic, never had a problem. And his cholesterol shot up, and his LDL shot up. And his doctor said, "You've got to go on a statin." And then he came to me. I said, "You know what? You're doing so well. I feel comfortable writing this out with you, and let's see what happens." Because his HDL went up, which happens when you're taking saturated fat. A lot of good things can happen. So that's a long answer to what I'm talking about. But I don't think a higher protein intake in itself will, unless you're taking a lot of saturated fat. And again, who cares unless you really have major heart problems. Okay, David, great news. Thank you. Is keto diet, what supplements might be useful? The important thing about a keto diet is that you don't restrict your salt. Okay, it's really important. In fact, they even have keto salts available for those that want to go ketogenic. And a lot of water. You have to drink a lot of water because it tends to be dehydrating. That's really it. I don't believe in I don't think you really need fancy supplements to add to a keto diet. And okay, I guess we are running out of time, guys. Hey, I want to thank you all. Okay, it's been a great audience. We go on and on. I'd love to, but some people get upset that I go over the time limit. So I want to see you in 2 weeks for our next session. And I think it's going to be on COVID-19, an update on COVID-19 and the heart. That's a big topic for a lot of us. And in closing, I want to say that this program and what I have to say is not meant to treat, diagnose, or prevent a medical problem. It's merely for informational purposes only. And you should always go to your physician for final advice and clear things with them. And if you like this program, and I hope you do, hopefully you've already subscribed to my channel, but if you could put the like button, that would be helpful so we can spread the word to other people. And I'll see you in 2 weeks, okay? Thank you very much, and good night.